Just a quick heads up before we begin. Everything in this episode was accurate when we recorded it, but things move fast in evidence-based medicine. For the most up-to-date and definitive information, then please refer to Red Whale Knowledge. And if you notice anything that might need updating or have any feedback, then we'd love to hear from you. Now, let's get started.
Hello, I'm Fiona Ritchie.
And I'm Nick Kendrew.
We're both part of the Red Whale team.
Come with us as we make your life easier and reignite your passion for primary care.
Welcome to the Frosty Mornings and Blue Skies Primary Care Pod from Red Whale. The Primary Care Pod from Red Whale.
So grab your preferred drink of choice, your trainers or your dog lead, and here's what's bubbling up as we dive in search of our pearls for the second time this month.
Genital warts, spotting, treating and referring. Still a common presentation in primary care and genitourinary medicine clinics, and depending on where you work and your skill set, you might see these often or actually infrequently. But are you confident in the diagnosis and what can be managed in primary care and what needs to be referred? How about what additional screening should be offered and what advice to give to those considering pregnancy? We'll look at BASH's 2024 update and cover all those points today.
The word addiction conjures specific images for each of us. Perhaps it's a person struggling to stop smoking in Stoptober, or a person who uses IV drugs. Or perhaps it's a behaviour more normalised and ubiquitous in our society. Alcohol, social media use, gambling or pornography all can impact health. We thought we'd share an article on addictive behaviours because there are so many things that we need to know and it's really tricky. But don't worry because we're going to simplify it for you. And we start our episode this time with the second pearl of the month, which is all about genital warts. But also remember to stay tuned because we're going to be giving you the answer to the £1 million question a bit later on. Now, this pearl on genital warts took me 8 minutes and 58 seconds to read. So how long did it take you, Fee?
Well, I can't play that game on this one because I'm actually in the video bite, which you lovely listeners can also watch if you prefer. So, yes, I think it would be unfair to say how long it took me because it would be a bit of revision.
Okay.
But what I thought we'd do is kick off with a quiz. Are you up for that, Nick?
Okay. Go on.
Little genital warts, true or false, and we'll just see how much of the article you paid attention to, not just how long it took you.
Okay.
Yeah.
Let's have a look.
Okay. And of course, you lovely listeners can play along too. So, first question. Genital warts are increasing in prevalence in the UK. So, listeners first. What do you think? Is that true or false? Have you locked in your answer? Okay. Now, Nick, what do you think?
Now, I think, looking at a wider picture, because of things such as vaccination programs and stuff, I think it's going down.
Yeah, that's correct. So that's false. So cases of genital warts are going down in the UK. Good. So that's a strong start in the studio here. Okay, second one. Genital warts are the second commonest infection diagnosed in GUM clinics, so sexual health clinics. Listeners, what are you going for? Are you going true or false? Okay, over to you, Nick. What do you think?
Okay, we covered gonorrhea the month before last, and that was the second most common STI after chlamydia. But we're talking about diagnosis in GUM clinics. I'm not sure. I'm going to say false on this one.
Okay, well, yep, that's a shame. It's actually true. You're right in what you said about gonorrhea, but actually in terms of diagnosis, diagnosed in genitourinary medicine clinics, it is the second most common infection diagnosed. Okay. So I can see your logic there. And actually, I'm going to say well done on building your STI knowledge. So that is good. So despite the reduction, genital warts remain the second commonest infection diagnosed in sexual health clinics. And that's 16% of diagnoses made. And that does come from the PHE Health Protection Report in 2018. So we, hope to get some newer figures on that soon.
Okay,
question 3. everyone needs specialist assessment and investigation. So, listeners, what do you think? Is that true or false? What are you going to go for? And how about you, Nick?
Okay, so at the beginning, we said about increasing our confidence in the diagnosis and that some can be managed in primary care. So I'm guessing that along those lines, it means that it's going to be false for this one.
Yes, well done. It is false. So,
I read the script.
Yes, well done. Yes. So the important points about this is that clinical appearance is diagnostic. Therefore, most people only need an examination when we're thinking about the sort of assessment and investigation. So, yes, can be done in primary care. So, well done.
Phew. Thank you for that.
Okay. So, now we've got that out of the way. Shall we settle into the pearl?
Yes. So, sounds good to me. So, why are we talking about this now, Fee?
So, as we just learnt, genital warts are a sexually transmitted condition which is actually on the decrease in this country, which is great, isn't it? And BASH updated their guidance in 2024, which we are going to look at.
And that decrease is due to the HPV vaccination programme, is that right?
Yeah, exactly. So prevalence of genital warts in the UK has fallen by 35%.
But hang on, didn't you say that genital warts remain the second commonest infection diagnosed in sexual health clinics?
Yeah, that's right. So despite its reduction, as I just said, 16% of diagnoses made in GUM clinics are genital warts. And because of the connotations of HPV infection and a general fear of managing sexual infections in general practice, it's tempting to refer patients with genital warts to GUM clinics. However, some genital warts can be managed safely in primary care, and we're going to look at that update from BASH and draw on useful RCGP guidance from 2013. So we're going to break it down into how we diagnose genital warts, what management options there are, and who we are going to be referring to GUM and why.
Okay, so let's start with going back to basics. What are genital warts? Well, anogenital warts are benign epithelial skin tumours. 90% of anogenital warts are caused by HPV types 6 and 11, which are not oncogenic. And here's a useful statistic. 30 to 50% of sexually active adults have HPV genital infection, but less than 10% have visible lesions.
And the mode of transmission is most commonly sexual, but remember that perinatal transmission can occur. And auto-transmission from hands has been reported as well, especially in children. The incubation period is variable, so generally 3 weeks to 8 months, but maybe up to 18 months or even longer. Some apparent new presentations will actually be a recurrence. Why is that important? Well, this means that appearance of warts does not indicate infidelity of a partner. And that's a question which may well catch us off guard. And knowing that and being able to explain that may be helpful.
Absolutely. And it's one of those things that you really need to know the answer to that, because it's a bit like if I'm on a flight and we hit turbulence, I look at the cabin crew and look at their faces to find out if I'm going to be okay. If somebody asks you that question and you kind of go, or don't pull the right face, then that could have really bad consequences for that relationship. So it's really important to know that, isn't it?
Exactly, yeah.
Okay. So thinking about our clinical diagnosis, warts may be found in the anogenital area, also the mouth, larynx, conjunctiva and nose, also the vagina, the cervix and the urethra, and the anal canal. And it's important to note that perianal warts are not indicative of penetrative anal intercourse, but anal canal warts are.
Yeah, and that was a learning point for me. And do be aware that people may not be aware of warts occurring in those extragenital sites, Nick, that you were mentioning. So, the mouth, the larynx, the conjunctiva and the nose. And so we should ask about those areas as well. So, as I mentioned earlier, as diagnosis is based on clinical appearance, examination alone may be the total of our investigations in the majority of cases. We should examine the entire external anogenital area and urethral meatus. And of course, we'll be offering a chaperone and, of course, documenting this. We should offer an STI screen if that's indicated. Now, speculum examination is not necessary in all cases, but it should be performed if there are warts visible at the introitus without a visible upper limit. And you might be thinking, well, why is that? Well, that's because internal warts, so those occurring in the vagina, the urethra, the cervix, or the anal canal, well, they're likely to need referral to GUM for their specialist expertise and wider treatment options. So that's one of those situations where we need to rule in or rule out because it will change our management.
Absolutely. And I think one of the difficult things is that genital warts can present in a number of ways. And when the clinical appearance is diagnostic, then that can be helpful if they're really obvious and we're confident that they're genital warts, or it can make things more confusing.
Yeah, I know what you mean there.
Yeah, exactly. So, for example, lesions can be flat or raised. They can be single or multiple, soft or keratotic. They can be small or large cauliflower lesions. They can be flesh-coloured or pigmented, and they can be a combination of all of these.
Yeah, and I think the important thing here is that if we are in doubt, then just grab a colleague to have a look too. I know it's easy to say that. Often we don't want to interrupt our colleagues or, anything like me, running behind time, trying to catch up, magical unicorn time. But it is one of those things where, another set of eyes could make a real difference there. And of course, do refer if you're concerned about the lesion being suspicious. And we'll come back to that in a moment. In typical cases, warts are usually asymptomatic, but anal, vaginal and urethral lesions may bleed, and urethral lesions may distort urine flow. So it's worth ascertaining this in our history taking.
Okay, so let's think about atypical presentations of genital warts and how to manage them. So we should think about anogenital neoplasia if there is pigmentation or depigmentation, if there's pruritus, if there's underlying immune deficiency, or if there's a prior history of intraepithelial neoplasia on the same or distant anogenital sites.
That's right. And if the diagnosis is in doubt or the appearance is atypical, then refer. And this would be either to gum, where a biopsy may be indicated, or via our suspected cancer pathways, depending on your clinical judgment. And we do have really helpful articles on suspected cancer referrals on Redwell Knowledge if you want some more information on that.
Right then, so on to management, and let's think about some general principles. As we said earlier, management is possible in primary care. Remember to set expectations. Treatment is cosmetic and it's not curative. The choice of treatment depends on the number of warts, their distribution, and also the morphology of warts, as well as the patient's preference. Firstly, no treatment is an option because in around 30% of patients, lesions can resolve spontaneously within 6 months. We can give sound general advice, so we can give a patient information leaflet about the condition, and Bash have got a great one which is linked at the end of the article, and you could make also an SMS template to include this, which is particularly helpful with the way that we're all working at the moment. Now, consistent condom use can reduce the risk of acquisition of HPV infection and genital warts by 30 to 60%. You might be thinking, what about previous partner notification? Well, this isn't necessary. However, current partners may wish to attend for examination, STI screen, and education about HPV disease. We should also counsel that wart treatments can give surrounding skin irritation. We should also say that imiquimod may weaken latex condoms. And we should discuss that all treatments have significant failure and relapse rates. However, complete clearance usually occurs eventually.
And we need to remember that the psychological effects of genital warts may be the worst aspect of the condition. And we can help here by reducing stigma and helping people to make informed choices on their treatment. So let's look at those now. And this is the bit of the podcast where I need to pronounce some difficult words. So here we go.
Good luck. In
primary care, we are most likely to be prescribing the self-applied treatments podophylotoxin and imiquimod. There we go. I did it right, didn't I? Okay. These have similar safety and efficacy, but podophylotoxin is cheaper and has a faster action. So maybe our preferred first choice. And that comes from Bash's guideline. Other options, such as cryotherapy or excision under local anaesthetics and ketofen 10%, are also included in the guidance. Podophylotoxin is licensed for genital but not extragenital warts, things like anal warts, and it is good for soft, non-keratinized warts. And this is applied as a twice daily regime for 3 days, followed by a 4-day break, and then we repeat that. And if there's no improvement after a month, then we need to try an alternative. So we might want to think about how, if we start that treatment, how we would then build in follow-up to that. Thinking about imiquimod, this is not suitable for internal genital warts either. It comes as a 5% cream and is sold under the trade name Aldara and is more expensive than other treatment choices. And this is applied nightly for 3 nights a week, so usually Monday, Wednesday, Friday, and then wash off each morning, and we can treat for up to 16 weeks. And to reiterate what Nick said, latex condoms may be weakened if in contact with imiquimod, which we need to consider and counsel for. But also to be aware that things like immune deficiency, for example, HIV, is not a contraindication for its use. Now, neither of these treatments should be used in pregnancy, as both are potentially teratogenic and should be avoided. And we're going to talk about management in pregnancy in a minute.
And if you want a summary of all of that, then there is a handy flowchart in the article. It's also on the video bite for how this treatment pathway might look for us in primary care. So do have a look at that. Sophie, who does need referral?
Good question. So these can be divided into presentation and special groups. If we think first about presentation, so earlier we mentioned internal warts. These, as you'll remember, need referral to GUM for assessment and to discuss those wider treatment options if desired. We've also discussed lesions that are suspicious or have atypical features need referral, and using our clinical judgment to decide if this needs to be under suspected cancer pathways. And then the other group in terms of presentation is persistent lesions. They need referral, and we should also consider an HIV test. Now, in terms of special groups, people experiencing genital warts in pregnancy should be referred to GUM. I think that's quite easy to remember, isn't it, actually? And treatment is not always warranted. Minimal lesions should be present at birth to reduce neonatal exposure, however, and to remember that C-section is only required if there is significant obstruction to the vagina or the cervix. So we might be able to give our patients a bit of information on that whilst doing that referral. Cryotherapy, excision and ablative methods are the safest options for treatment. We should refer immunosuppressed patients, and children, we should refer those. And in this case, of course, we'd be referring to paediatrics and considering a safeguarding assessment as well.
Thank you. So that's your lot. So let's think about some take action points. Do you refer all cases of genital warts? So consider how you might now treat in primary care, and also share your knowledge on who needs referral with a colleague. And why not let us know by emailing us impact@red-whale.co.uk. And here are our take-home messages.
Genital warts are on the decrease, but are still common, and some cases can be managed in primary care.
There's a clear treatment algorithm, which you can look at in the Pearl.
And we should refer suspicious lesions or those in special groups.
Are you a GP trainee or do you know one? We've got some exciting news.
We know that GP trainee years can feel daunting and expensive, so Redwell has joined forces with the MDU to provide a free education package tailored to GP trainees, which has been really popular. Nick, can you tell us about it?
Of course, this is the GP Trainee Essential Support Package, exclusively available to GP ST MDU members and affiliates. It's worth £165 and is designed to build your knowledge and confidence to help you pass your exams. So what does it include, Fee?
You get access to the whole of Redwell knowledge. That's over 900 written resources to support you during consultations and with exam preparation. Some of you describe it as like having an educational supervisor in your pocket. There's also a digital Top AKT Topics handbook, which contains topics that the RCGP says people find challenging in exams.
You also get access to 4 on-demand exam preparation webinars that demystify workplace-based assessment, AKT, SCA, as well as statistics and data interpretation.
And from August 2025, we'll be sharing a monthly video bite on common primary care presentations to support your learning even more.
So, who's eligible and how do they access it?
This all depends on where you are training. If you're a GP trainee in England, indemnity is provided through your deanery, but in addition to this, you can sign up for free MDU affiliate membership anytime during your training. You will then be able to access the GP Trainee Essential Support Package for free. And if you're a GP trainee in Scotland, Northern Ireland or Wales, you choose and pay for your own indemnity. Therefore, if you choose the MDU as your indemnity provider, then you will gain free access to the GP Trainee Essential Support Package. Just visit themdu.com to find out more. Click Choose to Join MDU and you can see all the options.
Once you're signed up, you'll receive a code from the MDU so that you can access GP Trainee Essentials as a free member benefit. And when you CCT, if you choose to continue with MDU Indemnity, then you'll get a free Red Whale course of your choice or a discount on Red Whale Unlimited to support you in your first year of practice. So, if this is of interest to you, then see the link in the show notes for full information and T's and C's, or search Red Whale GP Trainee Essentials to learn more. And here's Fee now with the Red Whale calendar for November 2025 and beyond into 2026.
So we've got lots coming up over the next few weeks. So some things sooner for your diary and some things to plan for. You can join Susan on Thursday the 20th of November digitally for the urgent and on the day care course. You can also join her on Saturday the 22nd of November for GP Update. And then if women's health is on your PDP, join us on Friday the 28th with Helen and Lucy. And on the same day, you can join face-to-face for GP Update with Susan and Hussein, and also on Saturday the 29th too. And then if blood results is something that you feel you need to brush up on, join Catherine on Friday the 5th of December. And then looking forward to the new year, we've got the lifestyle course on Wednesday the 14th of January, live with Hussein. All dates are on our website.
So we've got that one in the bag, and I didn't get a chance to talk to you properly last time. So how are you doing, Fee? What's going on?
Yeah, I'm doing right, thanks, Nick. I can't believe we are well into November now, which is slightly shocking. But
Yes.
What does that mean for us, Nick?
It means it's our birthday month. Yay!
Yay! We're both November birthdays, aren't we? So if anyone wants to shower me with gifts, they are very welcome to. You can send them in via Red Whale.
No, don't.
Or just don't encourage that. Or if you'd like to send us a happy birthday note, you can
Happy
text
birthday
in,
text.
can't you, Nick?
Yes, that's allowed. That's fine.
That is allowed. Yeah, no, I'm doing okay. I tell you what, I was inspired the last time I listened to the podcast. You and Ali were talking about all your hip workouts and getting active and everything. And I was very inspired. So how's that going, Nick?
It's going all right, actually. So I have been managing about 3 HIIT classes a week and really enjoying them. And I really miss them when I don't do them. And what's lovely about it is
good.
It's not just about feeling physically kind of stronger and sort of having a bit more muscle there, but it's also about mentally as well. I feel a lot better. It's great. Heartily recommend.
That's nice. And was it something that you'd done before? Or is it completely new?
I had kind of dabbled on and off with it. And in fact, I first did HIIT properly when I was in quarantine in lockdown, and I'd been on holiday in Spain, and I came back and they changed the rules literally as I was flying back. So I had to go straight into quarantine. And of course, work was still important. So I had to do all my normal work because we hadn't worked out how it would work. So I was actually duty doctor from home for a bit. And people were knocking on my door at the surgery and wondering why I wasn't answering the door. So we had to work on that level of communication.
Goodness me.
Didn't last for long. But yeah, so
it feels like such a lifetime ago in some respects.
It's a different lifetime completely. Yeah. But I was stuck in the house going stir crazy. And the thing that kept me sane, I bought a Joe Wicks
Wixie
class.
Yeah.
And I did the same class.
Were you doing the PE one with the children?
No, I'm not the live one. He was doing that live. That was a national thing, wasn't it? But then this was something I'd bought, and I think he'd filmed it around Lake Como or something, so it looked quite nice. So it was a program that I did. That was a long answer to your question, wasn't it?
It's just interesting because I was thinking about that, and I could wax lyrical about getting active, and I mentioned to you earlier that I ran the Great South Run on Sunday before recording this. Well, thanks. But I want to put a shout out if anyone else ran it, because the weather conditions were absolutely awful. It was rainy and cold. And actually, I feel like the spectators should all get a T-shirt for turning out in that. But if anyone was doing an event in the awful weather. But what I really wanted to bring up actually was rediscovering things that you might have done as a kid.
Okay.
So I was very lucky recently. My sister, bless her, and she doesn't listen to this podcast, so there's I'm not, no benefit of me giving her a shout out. But she got me like a secondhand keyboard, and because I was looking for one, and she got me one, and I've dug out a load of old like piano music from my piano lessons when I was a kid, and I've started playing, and it is slightly frustrating because I'm nowhere near as good as I once was, obviously. But I tell you what's interesting is knowing how my sort of growth mindset has changed over the years, because when I was younger, I just used to get angry and just say, I can't do it and I'll never be able to do it and have a little tantrum. Whereas now I just think, oh, that's fine. We'll just, chip away, and there's no deadline. I'm not doing an exam or anything. But it's just nice to have something else that's you're doing just completely for pleasure. No other reason than just something you're interested in. And it made me realise how nice it is to have those kind of things in life, especially when, as clinicians, we spend a lot of time doing things for other people, and, even within our kind of family units and social setups and things like that. So, yeah.
That's fabulous. I love the piano, and I miss it from when I was younger. But so maybe I'll look into starting that again.
Yeah. And I think also just thinking, when we're releasing these episodes, we're all going to be coming into that time just before Christmas where everything goes a bit mad, and, colleagues going obviously on leave, and loads of extra pressures with, I don't know, kids doing Christmas performances and buying all the gifts and, hosting family and doing all that kind of stuff. And actually, it's a really important time to make sure that we do look after ourselves and try and pace it a bit. So any which way you can find a bit of joy for yourself, totally for yourself. I don't want to call it selfish joy. I'm sure someone's coined a better phrase than that. But something that doesn't benefit anyone else, just you.
Yeah, just you time is important, I think. Yeah. Anyway, shall we move on to the next pearl?
Go on then.
Let's start off by pausing for a minute. And if it's safe to do so, then close your eyes and think of the word addiction. Now, what pops up in your mind? Fee, what do you think about when you heard that word?
Yeah, it's a good question. So for me, I think of maybe drug use, people who smoke, the people that I'm signposting onto kind of substance addiction services, really.
Yes, exactly. And the word addiction may conjure images of IV drug users, smokers, and cocaine users. But many highly addictive and damaging substances and behaviours are both legal and normalised in society. With ever increasing levels of stress and an increasing abundance of products and services using behavioural psychology to enhance sales, we're likely to see a growing impact on our patients and our own health. And as we go over our pearl on addictive behaviours, it will become clear that there are lots of things that we need to know as primary care clinicians.
Oh, Nick, please tell me, because I fear that quite a bit of this is actually in my unknown category.
Okay, well, I'm sure they are for many of us. So they are, what's the difference between addiction and impulse control? How can we identify addictive behaviour? What are the factors that make individuals more susceptible? And what are the specific considerations and approaches to social media use? Sophie, what did this one mean for you?
Well, I think I'd badge this one as the one that really made me think, really, because actually when you have a moment to think about this outside of the consultation, then you can start to see how what can start as maybe a normal behaviour moves across to a harmful behaviour. And then the identification of it can be a real challenge, can't it? Especially if there's denial from the person or from family members, maybe because there's some shame there as well, or the behaviours are hidden. So it really made me think about that, and also about just how many people can be affected by this.
Yeah, absolutely. And it's not just the people that have the addictive behaviour, it's their family, their children, it's their friends. The ripples of this are huge, and it's always something to think about. Yeah. Now, this one took me, should we say it at the same time?
Yeah.
Okay.
1, 2, 3.
23 minutes.
20 minutes.
And 12 seconds.
22 seconds.
Oh, so I always take longer than you. But yeah, but it's quite a...
It's a meaty one. But actually, it's a really comprehensive view of different types of addictive behaviours, which I think is really helpful if you're going to sit down and and read it. And at the end of it, I felt like, oh, okay, actually, I feel now I can think about these things in a more constructive way rather than feeling a bit bewildered in a consultation.
Yeah, exactly. And we're going to kick off in a moment with the classification. But before we start properly, let's go back and do the answer to the £1 million question. So this will help us focus our learning as we go through it. So if you remember, then the £1 million question was about addictive behaviours and impulse control disorders. So here it is. Impulse control disorders. A. Involve repeating a behaviour because it feels rewarding or reinforcing. B. Are driven by craving or compulsion, and stopping the behaviour may lead to withdrawal symptoms. C. Involve acting on sudden urges that bring short-term relief, excitement, or escape. D. Are usually seen across multiple contexts and situations. And the correct answer is C. Impulse control disorders involve acting on sudden urges that bring short-term relief, excitement, or escape. How did you get on, Fee?
I think I got it right, but you'd hope so because I just read the article.
Exactly. So impulse control disorders involve acting on sudden urges that bring short-term relief, excitement, or escape. Option A, so that was involve repeating a behaviour because it feels rewarding or reinforcing. And B, are driven by craving or compulsion, and stopping the behaviour may lead to withdrawal symptoms. They are both seen in a disorder due to addictive behaviours. Now, option D is an interesting one, and this is to highlight the difference between impulse control disorders and ADHD. Now, individuals with ADHD also commonly have features of impulsive behaviour. However, in ADHD, these are usually seen across multiple contexts and situations, whereas impulse control disorders are usually limited to one specific area, such as pyromania or kleptomania. Individuals with ADHD also do not typically experience tension or affective arousal prior to the behaviour, or a sense of relief or gratification once it's been completed.
That was a good one, Nick. I thought it was actually really tough.
Yeah, it was tough. But it's great to see how
good learning.
You can. Yeah, great learning from that. And it's lovely to kind of focus it all down to be able to have a closer look. Okay, so if we start properly then, and we'll start with classification. Now, the most recent revision of ICD-11 from the World Health Organization in 2019 introduced a new category: disorders due to addictive behaviours. This marked a significant shift, broadening the concept of addiction beyond substance use to include other behaviours causing clinically significant impairment. Some experts have welcomed this as increased recognition of the harm that addictive behaviours can cause, whilst others have raised concerns that it risks pathologising everyday behaviours, and that's from the Journal of Behavioural Addictions in 2022. Addiction can be split into substance addiction and disorder due to addictive behaviours. And as you'd expect, substance addiction includes alcohol, tobacco, and drugs, both illicit or prescribed. Disorders due to addictive behaviours would include gambling and gaming. There are also other disorders due to addictive behaviour. Now, ICD-11 does not list specific behaviours in this category, but defines them as persistent, repetitive actions with impaired control that continue despite negative consequences and interfere with daily functioning. Behaviours often discussed in the literature, though not formally recognised due to limited evidence, include social media use, pornography consumption, and shopping. Other patterns, such as excessive work or exercise, may also meet criteria for addictive behaviours.
Yeah, I thought that was really interesting, actually, because certainly things like excessive work or, exercise, sometimes, that's something that is encouraged or even celebrated, isn't it? But, it could tip into harmful as well.
Yeah, exactly. And it's something to watch out for too. Now, these behaviours reinforce reward, motivation, and memory pathways in ways similar to substance use disorders. Now, we're not going to cover gambling here because we cover it as part of the current season of GP Update, which has just launched. And you might have seen it on a recent face-to-face course or digitally, and it's available on demand. ICD-11 also lists impulse control disorders as well.
There are some key differences between addictive behaviours and impulse control disorders listed in the ICD, although both can involve repeated actions that can disrupt daily life. So let's start with disorders due to addictive behaviours. Let's think about what Nick has just said and see if any people that you've helped to diagnose or manage this whilst working in primary care spring to mind here. So these disorders have 4 key points, which are that they involve repeating a behaviour because it feels rewarding or reinforcing, that behaviour is driven by craving or compulsion and stopping it may lead to withdrawal symptoms, that there is an ongoing loss of control over how often or intensely the behaviour happens, how long it lasts, where or when it takes place, and the ability to stop. And it often takes priority over other activities and continues despite harm to health, relationships, work, or education. Now, let's compare that directly to impulse control disorders, which include things such as pyromania, which is the impulsive urge to start fires, kleptomania, which is the impulsive urge to steal, and compulsive sexual behaviour disorder. Now, what these share is that they involve acting on sudden urges that bring short-term relief, excitement, or escape. And those urges are often preceded by rising tension or a build-up of pressure. And the person feels unable to resist the impulse, even though they know it could cause harm. And the behaviour is usually followed by guilt, shame, or regret. But the question is, how do we know if someone is addicted? Nick, what does the guidance say on this?
Well, there's always a line, isn't there? And determining when a behaviour crosses the line from being socially accepted to clinically significant can be difficult. However, both ICD-11 and DSM provide criteria that help identify when a behaviour may be classified as an addiction. Key features include a pattern of excessive, repetitive and persistent behaviour, diminished control or a compulsive urge to engage in the behaviour, continued engagement despite clear harm to self or others, negative consequences across multiple life domains, including health, relationships, work, or education, a shift from pleasure to compulsion with the behaviour becoming less enjoyable over time, and recurring emotional cycles such as guilt, shame, anxiety, or craving linked to the behaviour. Now, it's all very well going through lists of these features, but what might this actually look like in the real world, Fee?
Yeah, let's think about how this might present to us in practice. And in the written Pearl, there's a helpful example. And as I read this out, just think to yourself what your differentials might be. So let's meet Felicity. Felicity is 18 and books to see you as she's been struggling with low mood for several months. She feels under a lot of pressure with her upcoming A-levels and can't get any revision done. So far, Nick, what are you thinking?
Well, it sounds quite understandable, doesn't it? Pressure at school, might be some sort of mood disturbance, anxiety, maybe something going on at home. I definitely want to know more about this.
Yeah, okay. So she spends most of her time in her room on various social media platforms. Even when she closes all the apps on her laptop, she ends up regularly picking up her phone during revision time. So, Nick, are you thinking about addictive behaviours yet?
Not yet. It still sounds quite normal in context for an 18-year-old.
Yeah, I have to say I'm quite similar at the moment. Shut down your laptop, pick up your phone and, be sucked in. So, yeah, I agree with that. Okay, so Felicity's story continues. She often declines social invites from friends and to eat dinner with her family because she would rather spend the time online. And when out socially, she tends to sneak to the toilets to check her notifications.
Okay, now I'm considering it. That kind of social withdrawal, the compulsion to check at home and when out with friends, that it takes priority.
Yes, exactly. And the bottom line is that she's unlikely to come in and say, hi, I'm addicted to social media. It's up to us to have that sixth sense and to tease out those clues and piece it all together. But Nick, I think something that all of us wonder about time to time is why are some of us more susceptible to addiction than others? Does anyone know the answer to that? Is there an answer out there? That's
a great question, Fee. And yes, they do. They do know. And you probably won't be surprised to hear that addiction is influenced by complex biopsychosocial interactions. And that's from the journal Physiological Reviews in 2019. Now, individual vulnerabilities include genetic or epigenetic variation. So studies looking at genetic risk in siblings have given a rough estimate of 50% for the contribution of genetics to overall addiction risk. Okay. Neurodevelopmental stages are also important. Fetal Childhood and adolescent development are times of greater risk for development of addictive vulnerability if exposed to drugs or adverse stimuli at those times. Childhood experiences are also classed as an individual vulnerability. So seeing addictive behaviours in parents or caregivers, seeing positive attitudes towards substance use, harsh or absent parenting, that can contribute as well. Sociocultural effects. Now, normalised cultural use of addictive substances, availability of these substances, their legal status, and the lack of social connection or social isolation are all factors as well. And then comorbid conditions. Pathological gambling and impulse control disorders are more common in people with Parkinson's disease than in the general population. The mechanism isn't well understood, but the dopamine reward and inhibition system may be involved. Drugs such as dopamine agonists may also play a role, and that's from Frontiers in Psychiatry in 2021. Mental health conditions are common in people with substance misuse disorders and vice versa. An association between substance misuse and depression, anxiety disorders, PTSD, ADHD, bipolar disorder, and psychosis has been shown. And that's from the US government website, National Institute on Drug Abuse, published in 2022.
Yeah, that makes sense, doesn't it? Because it does often feel very complex, and that shows, the scale of the complexity, doesn't it? So let's balance that with some neuroscience, because addiction is increasingly recognised as a neurobiological disorder involving lasting changes in brain structure and function that affect systems related to reward, motivation, stress regulation, and executive control, and that comes from Lancet Psychiatry in 2016. So addiction can be viewed as a 3-stage cycle. So you've got the binge or intoxication stage, where you've got cues associated with the substance become strongly linked to pleasure and habit, reinforcing repeated use through increased dopamine and glutamate activity in the basal ganglia. Then the next stage is the withdrawal or the negative effect. With ongoing substance use, the brain's ability to respond to natural rewards is reduced, while stress systems in the amygdala become overactive, and that contributes to negative emotional states such as anxiety, irritability, and dysphoria when the drug is absent. And then the third stage, which is preoccupation or anticipation, which we might also call craving. So this is where there's a dysfunction in the prefrontal cortex, which supports self-regulation, attention, and decision-making. And that leads to a persistent focus on seeking the substance. And that stage is marked by heightened sensitivity to drug-related cues, a reduced ability to experience pleasure from everyday activities, and increased stress responsiveness. And together, these factors intensify craving and increase the risk of relapse. And this cycle reflects a shift from impulsive behaviour, which is driven by the desire for immediate reward, to compulsive behaviour, which is driven by the need to relieve distress, although the two can coexist. And repeated substance use dulls the brain's response to pleasure, particularly through changes in the mesolimbic dopamine system, leading to tolerance and a need for increasing doses. And at the same time, impaired decision-making and self-regulation make it even harder to stop.
Operant conditioning may also play an important role in behavioural addictions. When behaviours are rewarded unpredictably with variable reinforcement, they become more persistent. This is demonstrated in gambling, where near misses, which are losses that feel close to a win, activate brain reward centres, reinforcing continued play. These responses are similar to those seen in substance addiction and help explain compulsive use. Cues associated with those rewards, such as lights, sounds, or notifications, can themselves become reinforcing, prompting behaviour even when no reward follows. And over time, this can shift behaviour from being goal-directed to habitual, continuing even when it brings less satisfaction or causes harm. Now, while gambling is well studied, behaviours such as social media use or shopping are less well understood in terms of specific reinforcers. The role of intermittent feedback, arousal or social approval in maintaining these behaviours needs further research, and that's from Clinical Psychology Review in 2017.
So let's move on and look specifically at social media addiction now. Social media is now deeply woven into daily life, particularly for adolescents who frequently rely on it for connection, self-expression, and access to information. And although it is widely used across all age groups, research has largely focused on adolescents due to their high levels of engagement and the developmental importance at their stage of life. And I think that it's generally recognised that problematic social media use and addiction exists. Now, Nick, you and I actually met to do a podcast episode on your podcast Boggle Docs, didn't we, a few years ago about this?
We did. So this goes back to 2020. It was November 2020, and we were talking about these. Yeah, I can't believe it.
5 years ago.
Yeah. And this is on Netflix. There's a documentary called The Social Dilemma, which talks all about this kind of thing. And the documentary is still live on Netflix now, so it's well worth having a look at. And when you've watched the documentary, then have a listen to the Boggle Docs episode, which is entitled Screen Time, Sexual Health, and the Christmas Lights That Went Very Wrong. So that's an enticing episode title for you.
Might have to go back and have a listen. Yes. But it was really, watching that documentary was really helpful for me to understand how social media platforms have been engineered to hit those reward systems. And so actually, if you're someone who's thinking, okay, I appreciate this, but I don't really understand it, then I think it's a really helpful thing to go and have a watch if you've got access to it. So Nick, what do the various bodies say about social media addiction?
Okay, so social media addiction refers to excessive and compulsive use that significantly disrupts daily functioning. However, this is not formally recognised in diagnostic manuals such as ICD or DSM. An alternative concept is problematic social media use, which is defined by the WHO as a pattern of behaviour with addiction-like symptoms. And these include difficulty controlling usage, withdrawal symptoms when not online, neglect of responsibilities and offline activities, and negative life consequences linked to excessive use. How common is problematic social media use, Fee?
Okay, so the Health Behaviour in School-Aged Children study, which was published by the WHO in 2024, surveyed almost 280,000 young people aged 11 to 15 years globally. It reported a significant increase in problematic social media use among teenagers. Findings included that 11% showed signs of problematic social media use, and that has increased from 7% in 2018, so there's an increase there. Girls were more likely to report problematic use, so that was 13% versus 9%, and continuous online contact. 34% of teens played digital games daily, with 22% playing for 4 or more hours. That's quite a lot, isn't it? When you've got to factor in school time as well.
Yeah.
Boys were more likely to engage in prolonged gaming, including at-risk patterns of behaviour. And risk factors for social media addiction include, and this comes from Frontiers in Psychology in 2022, female gender, high impulsivity, attention bias towards negative information, and low self-esteem and social anxiety, because this may drive individuals to seek refuge and validation through online platforms, reinforcing compulsive use. So, Nick, what have you got on the harms of social media use?
Problematic social media use is associated with multiple negative outcomes, including depressive symptoms, anxiety and psychological distress, cyberbullying and negative social comparison. I think we can all relate to that. Body image concerns and disordered eating, substance use, disrupted sleep, deliberate self-harm and suicidality, increased sedentary behaviour, and greater likelihood of risky behaviours such as alcohol, smoking or vaping, drug use, unhealthy diet, risky sexual behaviour, gambling, aggression. I mean, the list probably goes on even further than that, but it's quite shocking seeing all that actually written down. A longitudinal cohort study of young people aged 10 to 14 years found that the type of screen engagement may be more important than total time when predicting mental health outcomes, and that's from JAMA in 2025. Adolescents with high or increasing addictive use of social media, mobile phones or video games, characterised by compulsive engagement, difficulty disengaging, and distress when not using, had significantly greater risks of suicidal thoughts, suicidal behaviours, and emotional or behavioural difficulties. These patterns were more strongly linked to negative outcomes than overall screen time. The authors suggest that these findings highlight the need to monitor problematic patterns of use over time and to shift the focus from total screen time to include other indicators of digital media related risk. So having heard all of that, have you got any good news, Fee?
Yeah, I might do. Who's asking? Look, it is shocking to hear all those, but we also know the other side of the argument, which is that not all social media use is harmful, is it? And actually, when used in moderation and with intention, it can offer a range of benefits such as improved mood, reduced loneliness, social interaction and connection, and access to information. Of course, this underlines the importance of balanced approaches that aim to maximise positive outcomes whilst reducing those potential harms. Mm-hmm. So, thinking practically now, how do we as clinicians ask about problematic social media use?
Well, the thing is that problematic social media use involves more than just excessive time online. It involves compulsive use, emotional dependence, and disruption of mood, sleep, relationships, and daily life. In primary care, the Bergen Social Media Addiction Scale provides a helpful framework for exploring patterns of use. It's based on core features of behavioural addiction, and it can help guide conversations and support recognition of problematic use. There are also some strategies for self-management in the table that's in the Pearl. Those core features to identify and the self-management strategies are preoccupation and compulsion. Are they able to cut down or take breaks? Self-monitoring and awareness. Can they record how much they use, notice triggers, and keep to a usage plan? Negative impact. Can they follow values-based goal setting and prioritise offline connections? And have they tried to cut down? Thinking about controlling their environment and boundaries, perhaps utilising strategies such as mindfulness and urge management.
There are no formal UK guidelines yet for managing problematic social media use in primary care. However, there are some helpful strategies listed in the Pearl, of which things like motivational interviewing, building rapport, and counselling on co-occurring problems will be familiar to us. Remember, this is not just down to us in primary care or even healthcare. The World Health Organization emphasises the need for a coordinated approach to safeguard well-being in the digital age. These key priorities include starting digital education early and embedding digital literacy in schools, training educators and healthcare professionals to identify and support at-risk young people, promoting open, stigma-free conversations about digital habits in families and communities, and holding tech and gaming industries accountable for manipulative design and age-inappropriate content. And future efforts must recognise that individual strategies alone are not enough. Reducing harm will require shared responsibility across health, education, policy and platform design.
Fantastic. So here are your learning points for addiction. ICD defines addiction in two forms: substance addiction and behavioural addictions such as gaming and potentially harmful behaviours like social media or pornography use.
Addictive behaviours can cause psychological, social and functional harm, often involving loss of controls and continued use despite negative consequences.
Other behavioural addictions are not yet well defined in clinical guidance, but require holistic assessment and may benefit from psychological therapy, self-help strategies, and appropriate signposting. Now, if you're hankering after a Red Whale Knowledge subscription, then we're offering a 10% discount on Red Whale Knowledge for our fabulous Red Whale Pod members. How do you become a member, I hear you ask? Well, if you're listening to us, then you are part of our pod, so welcome to that. And all you have to do is go to redwhale.co.uk, put Red Whale Knowledge in your basket and enter the code RedWhalePod to get your 10% off. And here's the small print. The discount is only for this product and it won't work on anything else. And please also note that this voucher code is all one word and all lowercase, and it can only be used once. Red Whale Pod.
If you've enjoyed listening, which we hope you have, then please give us a 5-star rating on whichever platform you use. It only takes a few seconds and we'd really appreciate it. And if you could spend a little more time, then please leave us a nice review too. Because of the way the algorithms work, it means that other people just like you can discover us.
And of course, putting algorithms to the side, there is no greater recommendation than a word of mouth recommendation. So if you've got some value from listening to the podcast today, then don't keep it a secret. Please tell everybody that you know who might also benefit from listening. All the resources that you need are in the show notes, and all the links are in the show description on your preferred podcast platform.
You can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. If you want to see something about the podcast, then please use the hashtag RedWhalePod.
And the other thing that you can do if you click on the link in the bio is to leave us a voice message telling us about anything that you found helpful or would like us to go over.
You can also email us. Our address is podcast@red-whale.co.uk. And remember, we also have impact@red-whale.co.uk for all the changes that you're making down on the ground. Until next time, I'm Fiona Ritchie.
And I'm Nick Kendrew.
Remember to keep Red Whale Knowledge open on your desktop at work, so we're with you when you need that bit of extra information or reassurance.
Take care and look after yourself. Bye-bye.
Bye.